Okay, it's my pleasure to welcome Catherine Cuthbertson and Mary Oben Cadet to come and be our guest speakers for today. They've generously prepared some time to speak with all of the students about their work in public health. Catherine is in public health and Mary is in home health. So I'm just going to give you a little bit of a background about Catherine, and she's going to be the first speaker talking about public health. So she's a public health nurse and an international board certified lactation consultant, and she has more than 12 years of experience in public health practice. She's worked in infectious diseases, immunizations, and reproductive and child health. And she has a particular focus on infant feeding and perinatal mood disorders. She currently is working as the acting assistant manager role, leading the COVID-19 immunization clinics in Durham region. She got her Bachelor of Kinesiology degree at Acadia University, and then she went on to University of Toronto to complete her Bachelor of Science in Nursing. And in 2020, she graduated from Athabasca with her Master of Nursing degree. And I'll just read out another bio from Mary and give you a bit of information about Mary as well. So she's worked in the healthcare system for approximately 24 years, and 21 of those years have been in the community. After she received her diploma in nursing, she worked with the First Nation population in Northern Ontario for about 2 years. And then her career path has taken her to teaching, staff nursing, and nursing supervision. She's currently been with VHA Home Health for about 17 years as a best practice nursing supervisor in Durham region. She's an avid learner, and she's always looking for courses and workshops to advance her practice and career. She received her nursing diploma from Cambrian College in Boreal, and her Master of Nursing Science from Laurentian University, and her Master in Health Management from McMaster University. She's a certified Canadian hospice palliative care nurse with the Canadian Nurses Association. And I'm not sure if all of you know about CNA certification. So if you have any questions about that, you can always ask. And she's a Canadian certified nurse educator. She's attended numerous conferences in palliative care and community home health and presented at 2 conferences, one in wound care and the other in palliative care. So I'm very pleased to welcome both Catherine and Mary to come and speak with you today. And I'm going to pass it first over onto Catherine. Thank you.
All right. Thank you very much, Barbara. It's really lovely to be here with all of you to talk about public health. And, you know, it's something that I think even 2 years ago, a lot of people didn't really understand what public health did. And I think a lot of people understand what public health does now. So it's actually a really exciting time to be working in public health. And so I'm just going to make this very informal. Hopefully I won't bore you too much. Feel free to jump in with any questions as I go along. And there will also be time for questions at the end. So here we go. So some of the things I'm going to cover, just do a bit of a brief introduction in terms of how I ended up in public health and some of the things I've done. We'll go into what is public health, some of the principles and skills of public health practice, a little bit about a career in public health, specifically in public health nursing and how to get there and what are some of the opportunities once you are a public health nurse. A little bit about some professional development opportunities and educational opportunities, and then questions at the end. All right, so a little bit about me. It's all in the bio that Barbara read out. But after high school, I didn't think anything about nursing at all, and I decided I wanted to do a bachelor's of kinesiology. I've always been really interested in health sciences and also in things like social justice and advocacy and political action. And so I went the health sciences direction initially after high school. Quickly realized I didn't want to work in that area. And after a few years of working, I went back to school and I did the U of T second entry nursing program and got my bachelor's of nursing. I worked for a few years as a cardiovascular surgery nurse at St. Mike's. And after my first son was born, I had a lot of struggles with breastfeeding and with postpartum depression. And it was public health nurses that really helped me out and opened my eyes to what a public health nurse can do and be. And so after my maternity leave ended, I went to Durham Region Health Department, where I've been working ever since as a public health nurse. I received my lactation consultant certification in 2018. And most of my work in public health has been either in infectious diseases or working in the areas of infant feeding and perinatal mood disorders. And then in 2020, I graduated with my master's in nursing from Athabasca. And right now I'm actually working in COVID response, so case and contact management for Durham Region Health Department. And hopefully in the near future, we'll be returning back to school and we'll be doing a doctorate in nursing. So I just thought we'd start off with a little video about what is public health.
We're not able to hear the sound.
Sorry?
We're not able to hear the sound on the video.
Oh dear. Okay, let's see if I can get back. How about now?
No, I'm trying to think of why that might be. Because usually when it's embedded like this, it should be able to.
Leave it to me to have the technological issues. So that's okay. We can actually move along, and it's just a quick video. And then most of the content is contained in the rest of the presentation, so that should be okay. Everybody's okay with that.
All right, thank you.
Maybe what I'll start with is asking some of the students, if you don't mind weighing in. I won't pick on you, but if anybody wants to maybe weigh in on what they think public health is. Does anybody want to be brave?
When I think of public health, I think of a lot of social support services and shelter clinics and stuff like that. That's kind of what I think of when I think of public health. I know that public health has such a broad scope, but that's what I personally think of when I think of public health.
Yeah, those are good examples. Anybody else? No? Did anybody find that their understanding or perception of what a public health nurse does or the importance of public health has changed with COVID? No, that's okay.
We sometimes, sometimes people are a bit more quiet when it comes to answering questions. Sometimes they might put information in the chat. So if there's anything that pops up in the chat, then we'll look out for that too.
Okay, sounds good. So in terms of public health, I'll go over a little bit some of the principles of public health and how it got started. So this is, I think we all know who this lady is. This is our good buddy Flo. So Florence Nightingale is widely known as the first public health nurse, and almost to the point where she's become a little bit of a nursing cliche. But what I really like about her is that she liked to stir things up. So she wasn't satisfied with walking into a situation and seeing what was unfolding and just accepting what she saw in front of her. She wanted to know why. She wanted to know what was behind some of those the root causes of what she was seeing. And so she was one of the first people to look at health as something broader than, just an injury or an illness. She had a systems approach. So she would look at things from a much broader perspective. She understood the importance of sanitation and hygiene to prevent illness. She was one of the early adopters of the concept that there are determinants of health that can impact how healthy a community or a person is. And near and dear to my heart is evidence-informed decision-making. So taking research and also information from the community you're serving and putting it all together so that you can develop practices that actually meet the needs of who you're trying to serve. And she was also a big fan of advocacy and political action. So she was really one of the first people who started the practice of public health. In terms of public health achievements, sometimes we go under the radar in public health. A lot of people understand the role of a hospital nurse, and maybe a bit less so what a public health nurse might do. So some examples of what people have done in public health. Obviously, immunization is huge. We've seen that over the course of history with some of the standard immunizations that have eradicated or virtually eradicated a lot of infectious diseases that used to kill people. on a regular basis. And we've seen that the importance again of a mass immunization response with COVID. Things like seatbelt legislation, workplace safety, reducing smoking rates, control of infectious disease, which we have obviously seen over the last 2 years with COVID, improved maternal child health outcomes, and things like fluoride in drinking water. So these are all examples of public health achievements. And so even though they're not always obvious to us on a day-to-day basis, they are certainly there making a big difference. I won't bore you too much with the sort of public health infrastructure in Canada, but just so you have a general understanding of how it works. You have an organization such as the Public Health Agency of Canada at the federal level. So Dr. Tam, who a lot of us are familiar with from her press conferences about COVID. So she's the Chief Medical Officer of Health for Canada. The Canadian Public Health Association is a professional organization that's really valuable to join if you're interested in learning more about public health. And then there's lots of provincial and local organizations as well. So I work for a regional health department, and so we take information from the Ontario Public Health Standards, which is set out by the Ministry of Health, and that tells us what we need to focus on. So every few years they update those standards, and then we update our programming to meet those standards at the local level. So some of the foundations of public health. So at the heart of public health is an upstream approach. And what this means is if you see somebody falling into a river, or lots of people are falling into the same river, and you notice this over and over again, you could stand at the bottom of the river and just help everybody out. Or you could maybe try to figure out why they're falling into the river in the first place and go upstream and try to address some of those root causes. And I know when I was in nursing school, I found these concepts to be a little bit hard to put into practice or hard to understand on a real world level. And that has certainly been something that I've learned a lot over time working as a public health nurse. So understanding things like the importance of income and its impact on health. When you dig down deeper and try to look at the root causes of health concerns in the community, you often find it's issues such as that. Also a population health approach. So in public health, we focus more on the health of a community versus on the health of a single person. We always look at the social and ecological determinants of health, which I'm sure you guys have learned about in your program. And we focus on things like supporting healthy behaviors to create healthy communities and looking at a population health assessment. So again, population health looks at the health of communities. It includes things like health promotion programs, infectious disease surveillance to help prevent infectious diseases, harm reduction, looking at creating a safe built environment for people to live in. So you're really looking at broader issues when you look at population health. The social determinants of health are all of those different factors that interact and work together to impact how healthy someone can be. It's pretty widely accepted that income is one of the most essential determinants of health. And that has broad implications for things like your access to healthy food, your access to things like leisure time and rest, and the ability to develop, to access education and improve working conditions and things like that. So the determinants of health really allow us to look at the root causes of why people are experiencing issues with their health and work backwards from there. In terms of healthy behaviors, we, as public health nurses, we really want to help. We keep in mind those things like social determinants of health and what are these factors outside of a person's individual choice that would lead them to make choices that are not as healthy as they could be. But we also, at the same time, will work on health promotion activities that will help to increase knowledge and information about behaviors that can improve health. So examples of that are things like when they started to put pictures on cigarette packages to show some of the health impacts of smoking. Other examples with tobacco include things like working to change legislation so people couldn't smoke indoors. And all of these different approaches, as in addition to things like health promotion and health education, help to reduce smoking rates. So that's one of the really successful examples of a public health campaign. And it's another example of how public health nurses work at a policy level to try to help change things on multiple different ways. Population health assessment basically means using the information available to us at a population health level to help guide our planning and delivery of services. So a really good example of this in Durham region where I work is the health neighborhoods maps that have been developed by the epidemiologists that worked for us. And what they do is they look at various health indicators. So for example, life expectancy, emergency room visits in a year, smoking rates, whether children in a specific neighborhood walk to school, and they're able to put together these maps and bits of information that tell us a lot about what's happening in a community and what are the things that we need to focus on. One of a really good example of what this information can do is it can tell us how we can target our interventions depending on what neighborhood we're looking at. So one of our epidemiologists did a presentation a few years ago where she explained that if you take 2 baby boys born in Oshawa in this particular year, which was 2015, I believe, that the baby boy born in a certain neighborhood would live on average 7 years less than a baby boy born in a different Oshawa neighborhood. And that's controlling for other factors, for things like smoking and accidents and things like that. And so that's a really telling piece of information that can give us an understanding of some of the challenges faced in one neighborhood versus another, and making sure that we're able to create programs that meet those needs and address priority populations. And then, of course, there's emergency preparedness. So we've all heard the term pandemic a little bit too much in the last 2 years. And so public health is involved, obviously, in things like pandemic planning and response, but also things like natural disasters, addressing issues such as climate change. In Durham, we have emergency preparedness plans related to the 2 nuclear plants that we have in our region, and public health would play a role in that response as well. So in terms of public health core competencies, this is just set out by the Public Health Agency of Canada, and it talks about some of the skills and abilities that we want public health nurses in Canada to have. So in terms of public health sciences, what that means is basically understanding sort of on an academic level, things like the social determinants of health and health equity. In terms of assessment and analysis, that has a lot to do with being able to use the information available to you, whether it's epidemiology data or research or consultation with community stakeholders, with any of these sources of information to be able to determine what's working well and what's not working well and how we can help various communities and meet their needs. Policy and program planning, analysis, and evaluation. That's a really key part of what we do as public health nurses. So at Durham Region, what we do is in November and December, our various programs meet and we look at the Ontario Public Health Standards. We look at some of the information we have about our communities. We look at the research and we say, okay, what do we need to provide in each of these communities and how are we going to meet the goals set out for us by the province and make sure that we're able to adapt as we go along. So that's the evaluation piece. So looking at what we're providing, what's working, what's not, and what do we need to change over time. And so that's a really important skill in public health nursing. And so is partnerships, collaboration, and advocacy. So for example, our health department has partnerships with our local hospitals, as well as Ontario Tech university. And so we will often do projects that work with the resources at all 3 of these organizations to meet the needs of various people in the community. So for example, a few years ago, we developed with one of the professors at Ontario Tech a breastfeeding education tool with some of our public health nurses, and that's given out at our local hospitals. So that's a really good example of how we work together with various community stakeholders to try to meet the needs of our clients. In terms of diversity and inclusiveness, we really want to understand our communities. So public health is often, the actual practice is often at a local level. And we often are taking information that we're getting from federal and provincial level, but we're adapting it to our individual communities. And so it's really important to understand what those communities need. In terms of communication, as a public health nurse, you need to be able to obviously communicate on a professional level, but it's also one-to-one. So you need, in a lot of my work doing infant feeding and perinatal mood disorders, I'm working with new parents, often people who are emotional. Sometimes I'm having to try to help them through some really difficult and trying times and do it in a way that's empathetic and builds relationships. It's communicating with other collaborators and stakeholders as well. So that's a really key aspect of public health nursing. And leadership, of course, is extremely important. We've seen the importance of good public health leadership in this pandemic response, and we've seen it work well sometimes, and we've seen it not work so well. But in certain situations, you know, public health is really going to be taking the lead in terms of policy and in terms of putting different interventions into place. So those things are also really important. So in terms of public health careers, and you guys are feel free to ask me questions at the end if you have any questions about getting into public health. So typically the way that it works in Ontario is you, as long as you have your Bachelor of Science in Nursing, you're able to apply for a public health nursing job. I know in some areas it's more difficult than others to get a position in public health. Mohawk College has actually come out with their first postgraduate public health nursing certificate program in Canada. I'm going to be working on the infectious diseases course curriculum development for that. So that's really exciting, and that's a great way if anybody is interested in public health as a career and wants to learn a bit more and build up some of their skills before applying. That's a really good option. Again, COVID has provided a lot of opportunities for nursing students as well as new grad nurses to take on temporary roles in public health to see if it's a good fit and to see if they're interested, and that's always a really good option as well. I know it can be sometimes challenging to get public health placements when you're in nursing school. So, so any opportunity that you have to do that, to do a placement or to talk to somebody working within public health will be really beneficial for understanding some of the skills and information that you need to know. And then this is just my little plug for CHNIG and RNAO. So Mary and I both are board members for the Community Health Nursing Initiatives Group for the Registered Nurses Association of Ontario, and we have student memberships as well. It's a really great opportunity to meet other community health nurses and to network. There's opportunities for scholarships and bursaries and conferences, and so there's a lot of really great opportunities there. So I'd encourage you to get involved because it opens up another world of information and the ability to build relationships with other people working in community health. And that is it for me. Any questions from anybody?
I did actually have a question. It's more of looking at your expertise rather than how to get into public health, but I do have a question for you.
Sure.
Something that I'm a little bit curious with in regards to the home health aspect of things and being a public health nurse. I am a clinical extern at a hospital in postpartum. And so every once in a while. It's pretty rare, but I have seen it a few times where we've had to get CAS involved.
Mhm.
I wonder how you would do that at home, because in the hospital, it's a little, feel like it would be a little bit easier to communicate with the family and say, you know, this is like routine screening that we do. But when it's in somebody's home, how do you have that conversation with the clients?
That's a very good question. So I do some home visits. Mary might be able to speak a little bit more um, home health specifically, but I've certainly, in my role with working with infant feeding, have had to call CAS. And typically what we would do is we wouldn't do that necessarily in the moment with the person right in front of us, depending on the situation, unless it was an emergency and we really needed to get them there right away. And that is a really good example of the importance of good communication skills as a public health nurse, because it's not an easy call to make. It's not easy to make the decision to call CAS. It's not easy to talk to the family about having to do that. It's not easy. As a public health nurse, you're often building relationships with families that can last for years at a time. And so if you do need to call CAS, it's a matter of trying to balance that obligation that you have, because you do need to call when it is warranted, but also do that in a way where you're not going to break the trust of the family that you're working with. And that is often one of the ways that I found that really works is to focus on CAS as a partner, as a somebody who's there to support the family versus an enemy. You know, that we're all working together as part of the same team. And CAS is a great way to get a family resources and access to things that they need in order to have a happy and healthy family. And it doesn't always go well. It's not always well received, and that can be really hard when you have built those relationships. But it's the sort of thing that, again, you wouldn't be calling in all likelihood from the home. I certainly have not done that, but I haven't faced emergency situations where I would need to stay there until CAS arrived. So I don't know if Mary maybe has had some experiences in that regard.
Thank you, Catherine. We did have some experience, because what happened in our, in my area where I'm working, I work mostly with adult. But again, because when we go home, it's the client home, we need to be observant of everything. There was one time I have to involve, actually the nurse had to call me to ask me what to do, because the father took the the child hands, and put it in the stove and burned it. That one, yes. And then she called me to say, what do I do? And then whatsoever I said, what you do, finish your service and then come out of the house and then call and then report. And we have to report, like you said it, Catherine, because we see it's an abuse in front of us. And then but we did not involve, because we weren't providing care for the child, but it was happening in front of us. So we were witnesses it, we had to call.
Mm-hmm.
Yes, yeah, definitively. It's kind of the same thing also, like for elderly, like if we find someone abusing, we do have an obligation for us to call and report it. Yes.
Thank you for your answers. That's wonderful. I'm sure kind of figuring out what to say and how to deal with that situation will come with practice.
Yeah, and it's never easy. There's certain things in nursing that just don't get easier, and that's one of those things. And you get more confident in your ability to approach the situation in a way that you feel good about, but it's never easy. So
I can imagine, yeah.
And I was also going to make just a quick comment, just in terms of, because I've had experience with young mothers and young parents, and you know, there's a whole surveillance in terms of thinking that there might be apprehension involved. And so having those communication skills are really so important, and building that trust up with the client. And the fact that having CAS involved within a client's life is not a bad thing. It used to, you know, it always was thought of as a negative, but CAS is really working hard. They have pregnancy PAC workers, pregnancy, I don't know what the AC stands for, but they work specifically with high risk pregnancy cases to try to keep the family together. That's the aim. It's not to separate in a safe way possible. But thank you. Those are great questions. Does anybody else have a question? sure if nobody else has a question, we could pass it on to Mary.
Thank you. Let me share my screen.
Yep, we can see it.
It's perfect. Thank you. Okay. Thank you very much for having me today. I won't take much time to present myself because I know Barbara already did it. So before I start the presentation, one thing I would like to share, it's researches shows that most of the people, they prefer to be treated and or even die at their home, but it is the community health and home care nursing, it's really taking his places in the population and the healthcare. So before I start, does anyone have experience or knows what is home care?
I did some PSW home care work before.
Okay, okay, good. How did you find it, Samara?
I enjoyed it. I did a live-in home care one for a while where I would live at her house for 4 days of the week. That one was a little bit much for me, but I did enjoy it otherwise, yeah.
Perfect, good, good. So like Samara even explained it, she was doing some home care living in. So home care, it's really like it said in the word, there is home. It is where we do provide the care to the clients and the community and a one-on-one. In the past, when home care started, it was really only in the client's home. And as time passed, and then the environment is expense that I will share in the next slide. And then we'll provide the cares when we go in the home. So it's it's not only nursing. So when people receiving home care, they can receive different basket. It's PSW can goes, and then like Samra said, she works before as PSW, and then nurses, and then you have rehabilitation therapies as well, like occupational therapies, physio, nutritionist, and then you do have social worker, and then so all of them, in speech language as well, especially after someone have stroke. So this is all services, and then that the client can receive in their own home. So like I said earlier, it's like the care is provided really in the client's private home. And then can be provided also in school, because there are certain kids that suffering with certain health issues. So it's like we the nurse will go with the child in the school and provide the care. It's like sometimes it can be for diabetes, it can be for ostomy care. So they will go there and then to provide it wherever the client is at that time that need the care. So we'll go with them. And then there is clinics as well. And then a few years ago, at that time it was under the CCAC, and then what they did decide, it's like because they see there was a need for it, and they did open some clinics in different area, like in where I am in the Durham region, we do have a few clinics throughout the regions where the clients can go, especially if the client don't want to stay at home to wait for the nurse to come. So they will go to the clinics and then to receive the care. The process, it's a bit the same, but it's like instead of the nurse go to the client and then the client will come to them. Retirement home, we do go there and then we provide care to them as well in the retirement home, because this is where it is their home. Long-term care, in the past, we used to provide a lot of care in the long-term care, but as they've been expanding in the skills, we go less and less. It's time to time we will go for IV start, they will maintain the IV, but if they don't have staff on board that can do IV start, so we will be involved, the agency will be involved to provide it, the care. type of client that we service in home care. So we service the clients from infant to elderly. So infant, it's like after the child born, and then might have some health issues. So, and then we'll go in the home, provide care. We do have children with all kind of issues. There are kids that even in ventilator that we have to go in and help, so we can give some respite care to the moms. And then some of them, they have G feeds that we go, and then we help with the care as well. And it's really like any issues that they are having. Some even kids, we deal with some kids with cancer as well, that we can go and then we provide as well the care. Of some, it's just for an infection, and then we'll just go to provide IV treatments. Of course, children, and then adult, and then young adult, teenager. So this is where we provide our care. And then also it's the culture, it's any culture, any background, and then we don't look at the social determinants. So we provide everyone. It's like, even we do have some clients, sometimes they are homeless, and then for the period of the time we'll make arrangement with them to see where we can meet with them, so we don't discriminate. So who pays for the care? So home care, it's publicly funded in Ontario. And so the money, how it works, it's like the government give the money to home and community care support services. Actually, that name just changed. It's on the foot before, you might know names as LIN. So they were formerly LIN. So the contracted, the few agency, like the agency I'm working, for example, in my area, it's one of them. So we are contracted by them, and then we provide the services. And then of course the company will bill home and community skincare support services, and then they will pay like that. And then when a client is on home care, this is the benefits of it. Also, they don't need to buy for any supplies, whatever it's need for the care, they do not need to buy it. So it will be provided under the service. So like, for example, if they need supplies for wound care, so the nurse will order it, and then home and community care will send the supplies to the client home. And it's the same way we have a contract with them to send the nurse to visit the client or to provide the care to the client. It's the same way also they do have a contract with companies like pharmaceutical, and then to send the IV medication. The other way also, some people do, it's like it's private, because sometimes it's like it depends the timing, how much time they need or how much care they need. So sometimes the home and community support services don't cover that that amount of time. So clients, if they have insurance, they will go and then they will type in the insurance to kind of top up the service that they need. And then the same things also, like or if they don't, they will pay it privately if the person have the money. So it will be out of the pocket. Okay, and then type of schedule. So in the community, that now I will be focused more in nursing. It's like we do have two types of schedule. It's like shift or visiting. Shift, it's anything that from 3 hours and up, we do from 3 hours to 12 hours. And then visiting, it's like we consider that from 30 minutes to an hour. To an hour privately, but it's like with the contract that we have with ACCSS. So one visit for them, it's for 15 minutes to 2 hours. And so this is how we calculate it. And then for the shifts, it's like, it's a shift, the nurse will go there and then stay there for the amount of the time. But when for visiting, it's like the nurse have to go to house. It's like one client after another client. What type of service do we provide in home care? I know in the past it was very funny. I remember when I started, the hospital nurse, they was saying, "Oh, we just only do eye drop, the things like we don't do much." But it's like in community and home care, we do have the chance to really do a lot of skills. So we do wound care, all kind of wounds, like post-surgical wounds or burns and anything like amputation. So we do any kind of wound in the community. And also we provide IV care and maintenance, and we give them IV medication to PIC line, and then we do the start. So if all that type of care, and then of course we do urethral catheterization, and then we provide pediatric cares, like I explained earlier, like from infant to from the infant when the born, depends what is the health issues, and then the other care that we provide also it's palliative care. And then sometimes we receive the client when they just diagnostic or well they are in chemo or radiation treatment, and then we will follow them until they become palliative. It depends, like but for the palliative, we will be there with them with the journey. And then also we do provide care for chronic disease like diabetes. The same thing, if we have a client that just diagnosed some new diagnostic with diabetes, we'll provide health teaching with that client, and then we will of course teach them how to use the insulin, how to check the blood sugar, and then sometimes also like if they cannot do it, we will provide the teaching to the family member. So we work as a team in the community. This is very important. And then the other care that we do also, we even do certain drain in the community as well. So it's like there is a drain, like for some clients, it's really helped them to avoid them to go to the hospital, like the one with lungs cancer. Sometimes they used to go to get drained. So in the community, there is one system that we use. It's called Plex. So they put it in the hospital, and the clients come, and then we can drain the client chest when fluids build up in the chest, so to avoid them to go to the hospital. And then of course we provide many more care. Basic skills need as a home health care nurse. So at the beginning to start, as a home care nurse, if the nurse have a basic assessment skills, that will help. And then because in the home, when you go, you need to assess the client, because you are the nurse will make the decision and the frequency of the client visit, how often you should see the client, and then what type of treatment can we be used, especially for wound care. Some doctors will be adamant, they will send the order, they will say this is what you need to do. And then some doctors also will send order that is not really best practice. So this is what the assessment skill is very good. And then wound care, it's like at least if the nurse have a basic wound care knowledge, they will be able to function and to work in home care. And then IV management, IV start will be a plus, but at least if they know how to do IV management, and then if they can work with certain pump that also help in catheterization, like for male and females, so that's also help. And then health teaching. This is the biggest one, because we do provide a lot of health teaching and and home care, especially like if you know, like the difference between the hospital, yes, they do provide some health teaching, but they're there if something, they just ring the bell. But at home, we are not there with them. So it's like we have to really teach them, for them to understand, to have the knowledge, what it is, what they are dealing with. And then, so they know also the sign, like if, for example, a wound care, we need to teach them the sign of infection. So they know, oh, okay, if it's look like that, I have to call the nurse what to do. So this is the basic skills that we really need in the community. And some soft skills that required as well, it's like it's well organized, because you need to organize, to know to organize yourself, because there is travel time, and then the time to provide the care. So that takes the skills. And then communication, and then I will reiterate, I know Catherine did stress on it earlier. So in the community, it's even it's very, very, very important as well, because you do need to communicate with doctors. So the same thing, like if they send an order, the order it's not right, so you need to communicate with them. And let's say also if they prescribe something and then that doesn't really do nothing, it's not relieving the client, so we'll need to call and then also like to for them to change it. And then we are in constant communication with home and community care services support services as well, because it's like we have to give them update on the client status, because this is it's based on the client status. So we change the frequency because they have to approve the frequency also that we are proposed in order to provide the care. And then also with family members as well, because remember we are in the client home. So we have to be really like have good communication skills to know how to approach the client. And also the other thing, it's non-judgmental. It is very important, because especially when you are going to the client's home, because when we're servicing all kind of clients, and then the social determinant will be your environment is different. You will go, the house can be really very dirty, or you don't have much things and whatsoever, or it can be infested with whatever bed bugs or something. So it's really need to be non-judgmental, and then to be focused and the care that why we are there really for the clients. And then of course we can be at the same time an advocate for them if we see the condition, and then there is things that we can do. We need to do that also. The advocate, it's another big one, because the same thing, you can go to a client, they send us like for nursing services only. When we reach there and then we see the clients are not very mobile, or they are unable to provide them the care for themselves, personal care. So in that case, we will have to advocate for them with home and community services, kind of to send PSW. And then for the mobility, we'll need probably to involve OT, PT. So this is where advocating for them, it's very important. And listening as well, it's very important, because we are working with them. So we need to listen to their needs, because I know most of the time we do it all in the healthcare. We go with our own agenda, and then we forget to consult with the client and to see what do they want, what do they need. So it is very important to have good listening skills. Also when we are working in community. And other things, another skills also, it's patient. It's one also that we need, because sometimes we might be there, but the client, they are very low, they're not at the same level with us. So especially when the client have a new diagnostic with something, and then we're starting to teach them, we want them to take care of themselves, and then they're not doing it. Sometimes it's not, because I know sometimes in healthcare we use the word non-compliant. Sometimes it's the client not there yet. So we need to be patient with them and to give them space for them to kind of to move along, and then for them to continue to the treatment. What are the benefits of for a nurse to work in the community? There are many benefits, but I just put a few here. And then the benefits, it's like you see different clients, and then the assignment, it's like on a daily basis. So your schedule, your assignment, it's changing every day. You're not doing the same thing, so you don't really get time to get bored. And the other things also, because you see different clients, clientele, and then also with different skills. As a nurse in home care, you really have the chance to increase your skills fast in a fast pace. And then you do have a lot of skills. After nurse work in community, majority, you can work in many different floor and specialty, like in the hospital, because you will see it all. The other things also for home care, it's client-centered care. Yes, in the hospital or any facilities, we do try to apply client-centered care, but in the home care, it's really like it's a good place to apply client-centered care, because we are in the client's home and the environment, and then we have the time also to sit and then to listen to their needs, because we are in a wash, but not like in the hospital. And the benefits, it's flexibility, because in home care, you do have the flexibility, because you do your schedule, like I said down there itself, you schedule yourself So like that, it's like if you have a doctor's appointment, you can arrange when you're going to see the clients, and then you can go in your doctor's appointment. You don't need to take the days off or use your vacation to go see a doctor. And then you work autonomous as well. That also help you to increase your autonomy as a nurse, because you are by yourself, and then it's push you also to learn more, and then put you also to really do self-assessment, because you need to be able to assess yourself. Do I have the skill? Do I know it? Do I need help? And then you need to know when to call for help. So it help that. And the therapeutic relationship, it's another one also, because it's because you have more time to talk to the client, and then you are in the client environment as well. So that help increase and then elevate it and then practice the therapeutic relationship with your clients. Challenges, of course, like everywhere, when there is benefits, there is always challenge. We never find one without order. So you do have the documentation. So it can be a challenge, because now most of the agency, they do use electronic device for the documentation. Of course, sometimes the connectivity can be an issue, especially in Durham when we go further north. So in that case, like when you go, you bring your tablet, and then you're not able to to do your documentation right away, because there is some connectivity issues. So in that case, you will need to kind of write the information on a piece of paper and then take it home, or whenever you have connectivity, you can do your documentation. And of course, if it's in paper chart compared to the hospital, a nurse have to document before they leave the home. But in community, you might find some of the colleagues that did not put their notes, and then when you go, you don't find the recent notes in the client's home. This is something that we experience in the in home care. And then isolation, yes, you are isolated because most of the time you are by yourself in your car, and then you go to the client. That not stop, like if any issues, you will call the agency to talk with them, but it's definitively an issue, because you by yourself. It's not like in the hospital, when you have an issue, you can tap to your colleagues on the shoulder, but in the community, you have to really take time and then call. Boundaries, we find it's a lot of it is a challenge. There's a lot of issues, because the nurses are in the client's home, so they find it very hard to create the boundaries with the client, especially when you have a client you're doing services for long term. So for them, they will say, "Oh, you are my family member now," and so on. So it's something that it's always a challenge for the nurse. Certain things they have difficulty to say no to the clients. And family conflict, this is another challenge as well. So sometimes you can be in the middle, or you can even be part of it, because it's like the way you want to provide the care, or you're teaching the family, and then they're not in agreement with you, and then they want to do it their own way. So we encounter that sometimes as well. So it is something that to always bear in mind, that can happen at any time. And then driving, same thing, because again, we have to drive a lot, because you go to client if you're not doing shift, so you have to drive to one client to another client. So if someone don't like driving, so home care won't be the best for them. Of course, with driving, when there's bad weather, it's called fatigue. And I think Catherine already talked about our NAO. So we are a member of our NAO and CHNIG. And also, like, they do have a lot of support they provide to the nurses, bursary, stewardship. And it's a place also, if you, any of you, after you're done, you want to go to further your education. So our NAO can help as well. And then, like Catherine said, they have for CHNIG, there is a student fee, so it's cheaper now, like while you're a student, because you can start taking the advantage of that our NAO and CHNIG offers. Okay, questions?
Thank you so much, Mary, for that. That was, I have my, I wear a hat both in public health and in home health, because I did work in home health for 5 years and with St. Elizabeth. Questions from students? Katrine, a lot of wonderful information, super informative. Thank you, Katerina, for the feedback. Does anybody have questions that they would like to ask, Mary?
I have a question.
Go ahead.
How often, thank you. How often when you go into a client's home do you encounter an emergency situation?
Not let's say it's not that very often. Time to time we will. One thing that we encounter very often, you won't believe it. It's like we find the client dead. The client die in their home. It's like this is why, again, this is why when we're saying the communication and then the advocate and then the connect, like to connect with whoever provide, like the home and community and then the organization. So it's like when we don't find a client, we have to do our really big diligence so we can know where's the client. A few times the nurse, we do have to call the coroner and then to come. But emergency first aid, we do have a few, but it's not that often. But because I think I can even count them, and then I've been working with in the home care for a while, and then the past, I can say even with that company that I'm working now, the past 17 years, if I recall, I can say 3 big emergency that we dealt with.
Oh, wow. Okay.
Mhm.
I see that there's a question in the chat that says, would you recommend doing home care, home health as a new grad?
Yes, actually, it is a way like if you go to the company that really provide you support, yes. And then, like I said, because there is a lot of skills, this is a place actually you will learn a lot. You will amaze of yourself. Because remember, like as a student, you do have some knowledge, you're novice in certain skills, but the knowledge is there. You learn all of it already, like the basic, like wound care, you do some basics, and then assessment, it's something like you as a nurse, a new graduate, you're starting doing it from the beginning until you graduate. So you do have the basic knowledge that you can definitively be successful. And then if you find the right agency that will be behind you and support you. I do hire a lot of new grad. And then they become my the best nurse.
And can I just ask, now that we've had, I know a lot of students have always been so concerned about not getting enough skills because they might not have had enough practice. During COVID, a lot of the placements were cut short. They might have been doing some remote placements. In the community placements they've had have been, sometimes they've been in outpatient clinics, sometimes in a community health center. No public health placements, obviously, during COVID. That would never been possible. But it's then also sometimes they can be working with a community agency or with a shelter, and they're doing much more project-based work or long-term care. So sometimes the students feel, I know a lot of year 3 students, you can tell me if you agree with this or not, but that you're feeling, that you don't have, you're worried that you might not have the skills. Is that right, students?
Yeah, that's how I feel.
And so if they were to start off in either public health or home health, which are, like, I know public health jobs are hard to get, both are can be hard to get. But in terms of that mentoring, what does that mentoring look like for a new grad?
Like I can talk in my I won't say my organization, but the nurse that I do work with, because I do supervise them. Like at the beginning, I will send them out at least between 1 and 2 weeks with a nurse, and then for them to follow the nurse. And then after that, we continue. They will starting after 2 weeks by themselves, and then we will I body them up with a nurse that have experience, so they can call, like it's like they encounter an issue or skills they don't know, so they call that nurse and that nurse go with them. So it's like it's a continual mentorship. That this is how I do, like in my area, how I work with them.
Is there any difference in the context of COVID? Like if you've hired anybody, like say this year, because maybe like the newer students like this, who graduated in the past year might have had a little bit less clinical time. Is it still, do you extend it at all past the 2 weeks, or is it generally still enough time? Or
what we've been doing, because it's like even though the 2 weeks I'm saying, it's like they do have the corporate orientation as well, where they do give you some skills with them. Actually, we do expense that also.
Yeah.
The corporate, they expense some skills like for own care, and then certain basic skill that we know they need, and then they do that, and then it's kind of when they go in the community with the nurse, they kind of focus on applying those basic skills for that time. And then when they are with the nurse, and then my motto, the way I said it to the nurse, it's like, let them do it. Don't let them shadow you. Only the first day they can shadow you, and then kind of gradually let them involve so they can do it. And then by the time they finish, they can really be feeling confident that they can do it. And then again, also, even when I put it, it's not really stone, because some nurses do need more support. And I always tell them that we start with that, but if they need more, I extended it, because I rather that they be competent and then they're able to provide the care than just rushing them to go work. I know it's like we're short of staff, but it's like my point also, it's like if they find it too much to overwhelm us, we have the risk to lose them. So it's like I'm trying to provide them that support. Yes.
That's great. Thank you. Catherine, did you want to make any comments about new grads at all, or?
Yeah, I think, public health is a very different field, I think, than a lot of other fields. And I do think if you're somebody who knows already that you want to work in public health, there's no harm in jumping right into public health. I work with a lot of public health nurses who have only done public health nursing as part of their career. And certainly I think there's aspects of if you work in a hospital or in home care first, there's certain skills and perspectives that you would have that would certainly add to your experience as a public health nurse and be beneficial. But yeah, I think in terms of starting in public health, I think the biggest barrier is, as you mentioned at the beginning, it's hard to find placements in public health for students, and often students don't really understand what public health is when they graduate.
Mm-hmm.
And so I know I didn't when I graduated from my program, and I kind of happened upon public health over the course of my career, which is one of the nice things about nursing is you can reinvent yourself as many times as you want. But yeah, I think our orientation program is usually pretty comprehensive. Again, COVID and doing it all virtually, I really feel for people who are trying to orient as a public health nurse in this environment without having met people, because a lot of what we do is face-to-face, and it's meetings and it's collaboration, and it's harder to do that virtually. But typically it depends on the program, but you would get an extensive orientation, and it's usually tailored to the person rather than the time frame.
Mm-hmm. Mm-hmm.
Thank you so much. I know it's for after 7. I don't want to be kid 7:06. I don't want to be keeping you longer than you've scheduled for it, but I just want to say thank you so much. I hope that the nursing students found this helpful. I'm always love having guest speakers and talking to you about your jobs. And that's one thing about academia. I love teaching and doing research, but I really miss being frontline as well. So it's hard. You just can't do everything, but
No.
and it's so, but anyways, I live vicariously through students and other people. So
Yeah, there you go.
but thank you again so much. And I'll stop the recording. And